Good afternoon, everyone. Thank you all for joining us for today's Power in the Public Narrative webinar as a part of the Celebration of Healing series with Congo Square Theater in celebration of their production, How Blood Go. I'm Jamira Alexander, the President and Executive Director of Public Narrative, and I'm incredibly excited to share a project that is included in the Healthy Chicago Equity Zone model. The city has 6 equity zones, and this project that will be presented today will focus on pregnancy and postpartum experience in Chicago's neighborhoods with increased adverse maternal outcomes, a community-centered qualitative study. At this time, I'm going to hand it over to Pamela Milan Alexander and Jenna Wallander, and immediately following the presentation, we'll have a Q&A by journalist LOreal Thompson. Ladies.
Thank you very much. Hi, good afternoon. I'm Jenna Wallander-Gemco. I'm a research associate at Align Chicago. I'm a nurse by background, but have been in public health research for the last several years. And I'll turn it over to Pamela to introduce herself before we start.
Good afternoon, Pamela Milan Alexander. I am the Community Engagement Director at Everthrive Illinois. I have been involved in maternal programs for over 20 years. So I'm excited to get started and share with you the great work that Alliance and Everthrive of Illinois has.
All right. I am now sharing my screen. Pamela, can you just confirm that I'm sharing correctly?
Yes.
Okay, great. So I'll go ahead and get started. Today, Pamela and I are going to be talking about the Chicago Collaborative for Maternal Health, which is a partnership between Alliance Chicago and Everthrive Illinois. Those are headshots. So the Chicago Collaborative for Maternal Health was a funded project by Merck for Mothers, which is a foundation from the pharmaceutical company aiming to support community-led efforts to address maternal mortality and morbidity across the country. Our partnership in Chicago was one of 19 cohorts that were founded and established through this funding. So we were established in 2019, and this partnership really sought to combat the maternal mortality and morbidity crisis in Chicago by building awareness in communities and government, fostering collaboration among health and social service providers, and driving quality of care in ambulatory care settings. So we had 3 aims out of that partnership. The first aim was to develop a quality improvement collaborative for ambulatory care providers focused on best practices in maternal health through systems and culture change, which was led by Alliance Chicago. So that's what I'll be talking a little bit more about. Aim 2 was to implement a complementary community engagement effort that informs family and community and social service providers about maternal morbidity and mortality prevention, which was led by Everthrive. And aim 3 was to determine and advocate for policy recommendations based on the learnings from aims 1 and 2, again, was led by Everthrive. So I'll start with aim 1. First, quickly about Alliance Chicago. We are a health center controlled network of federally qualified health centers, both in the city of Chicago and across the country. Though we were founded in Chicago and the work for this project was led in Chicago. This work in our organization was led within the health research and education arm under our service lines. So to develop a quality improvement roadmap and kind of a plan of action, we had to engage a lot of different stakeholders and particularly federally qualified health centers in the city of Chicago, both within our network and kind of outside of our network, knowing that F2HCs serve a lot of different neighborhoods of Chicago and not all of them are in the Alliance Chicago network. So I'm not going to go through this specific chart line by line, but you can see that this was a really very intentional process to make sure that whatever quality improvement initiative we implemented in the city was community-led and informed by our F2HC stakeholders. And we also leaned on the expertise of the Illinois Perinatal Quality Collaborative. So overall, we engaged 18 F2HCs and community health centers and ambulatory care centers within hospitals across the city, with 13 ultimately deciding to participate in our QI subcommittee, which was the arm that we used to vet ideas and kind of develop this quality improvement work together. And then we surveyed those groups and did a community health needs assessment to see what they might be interested in prioritizing from a quality improvement perspective. More than 60% were prioritizing the postpartum period or interested in prioritizing the postpartum period. And more than 80% were interested in linking to primary care provision after a medically complex pregnancy. And that's actually an ACOG recommendation that came out in 2018 that all postpartum patients should transition to primary care. But there also is this specific interest on high risk or medically complex pregnancies because the postpartum period is a really important time to engage and prevent maternal mortality and morbidity. So from there, we developed quality improvement intervention. We had 3 health centers from that larger group participating in a smaller cohort that we called our QI development team to kind of get into the nitty gritty and the details. And then 6 health centers actually fully implemented the quality improvement initiative, with 5 still implementing. The quality improvement initiative or implementation that was designed was a population health registry approach of identifying high-risk prenatal patients at a given health center, and then following up and coordinating their care. So our global aim was to improve the number of patients with pregnancies complicated by medical conditions who were linked to primary care provision within 6 months. So that was after routine postpartum care. But we also looked at some other structure and process measures, as well as we were also looking at the additional outcome measures, just to look at postpartum visit attendance as well, just to see how the health centers were doing in that. So we were really looking, at, were criteria defined for high risk at each health center? Is the registry process in place? Is a process in place to coordinate care? Where is this being implemented? That sort of thing. And so in terms of the high-risk criteria, each community health center selected their own high-risk criteria that was reflective of their own patient populations. So 100% of sites were interested in diabetes or gestational diabetes. So all of them were tracking high-risk patients with those diagnoses. Some of them were also looking at hypertension and preeclampsia. A couple of the sites had already in place a risk stratification process that they just layered the postpartum period in. And then 2 of the sites were looking at depression as well. And so in terms of our most important global outcome, the number of high-risk patients accessing primary care visits, you can see in our baseline period, which was 2020, 25% of high-risk patients were transitioning to primary care within 6 months. And we, through this implementation process, almost tripled it to 72%, which was just really exciting and a huge testament to the work that the health centers were doing. We did do some additional evaluations as part of this work. We did a secondary data analysis of postpartum care across our Alliance Chicago network, so not just the sites in Chicago. We wanted to see if that primary care transition rate in the baseline period, that 25% rate, was accurate across the network and or influenced by the COVID-19 pandemic. So we looked specifically at patients with a pregnancy in 2018 to see if they got a primary care visit within 6 months of delivery. We were looking at high risk status, insurance status, and engagement in care, really looking at did they have a first trimester visit? Did they have a visit prior to even establishing prenatal care where they engaged patients? So in our overall cohort, we found that 85% documented a postpartum visit versus only 17% with a primary care visit. And risk status, insurance loss, and engagement in care were independent predictors, but still not very high attendance rate, even with those positive predictors of primary care. Among the high-risk cohort, again, similar findings, 25% with a primary care visit. So the bottom line really from that analysis was that the majority are not making the transition to primary care. And this was obviously a really big opportunity for improvement, but validating to see that what the FQHCs we were working with were seeing anecdotally on the ground and kind of in these small scale pilots was also confirmed in this large scale data analysis. We also did a qualitative study with the University of Illinois at Chicago. They interviewed a lot of the stakeholders who were participating in our QI collaborative to see what that experience of participating in quality improvement was like for them. In terms of facilitators, this might sound familiar if you're in these types of roles. Support from Alliance Chicago, communication, and then the flexibility was the biggest key in terms of the success of the intervention. Barriers, this also might be familiar, resources and capacity, training, and then internal communication in terms of being able to communicate what was going on in their health center environments to make this initiative work. So kind of what we learned from this work in AIM-1, really how valid a community-led and CHC-informed approach, how key that was to our success. Again, that QI topic that we went with and the evaluation approach were selected and designed with the QI subcommittee and the FQHC partners we were working with. The baseline data and the secondary analysis we did confirmed the gaps that we identified. And then the health centers also designed their workflows based on existing processes. So there wasn't a pre-baked idea coming in where some sort of rigorous, rigid methodology. It was really meeting the health centers where they were at. And has led to continued engagement and sustainability. 5 out of the 6 health centers that implemented with us are still continuing some of those workflows to connect patients to primary care. And we're still working in various ways with the subcommittee and reaching out to the FQHCs on new ways to support this work and improve postpartum and prenatal care for their patients. And with that, I will turn it over to Pamela.
Thank you, Jenna. Thank you so much. Next slide, please. So just to provide a little background on our work at Everthrive Illinois, our mission is to achieve reproductive justice in healthcare, in the healthcare ecosystem through community-driven partnership, policy action, and systems change. Our vision, a just and affirming healthcare ecosystem where individuals, families, and communities can thrive. And then our values are reproductive justice, of course, anti-racism, centering the most impacted, bold action and transformation. So you heard a lot about how we got there. Now we're going to focus on the community engagement piece. So a part of AIM-2 was, of course, to work with, or the goal was to work with community members and partners to develop and implement a community education campaign to promote maternal health and improve trustworthiness of healthcare systems. The process started with a community needs assessment, followed by us engaging in community by doing survey collection, focus groups, and training social service providers. And then it led to our community responsive health campaign. Our guiding principle, of course, in this was that the people with lived experience are essential to the work that we're doing in identifying the barriers to care and identifying or helping transform, the healthcare system to better support pregnant and postpartum persons. Next slide. So our methods. We had boots on the ground, of course, so we did outreach at health fairs, community events, pop-ups, back to school events, and some of the local businesses like the nail shops, some of our barbershops on the west and south sides of Chicago. So we did a lot of outreach in those areas. We completed 330 surveys and 4 focus groups engaging pregnant and postpartum people. And in particular, those communities were East and West Garfield Park, Austin, Inglewood, Greater Grand Crossing, and Chatham. And then there were 12 social service organizations and more than 100 social service providers trained based on our engagement efforts. Next slide, please. So we did a focus group qualitative analysis. The objective was to use the focus groups to understand the pregnancy and postpartum experiences of Black Black pregnant and parenting people living in economically disadvantaged neighborhoods in Chicago. And our primary questions to them were, what types of support in the antenatal and postnatal period do women have access to? How do people who are pregnant access health care and health information? And what are people's perceptions of maternal morbidity and mortality? And so this was a community-based participatory research. You got to excuse me, probably too much coffee this morning. 4 focus groups facilitated by community health workers. Our participants, once again, were Black parenting or pregnant individuals who lived in select neighborhoods in the South and West Side of Chicago. They did deductive and inductive coding by peer analyst teams, and they did a thematic analysis. So as you can see here, these were some of the questions, and based on our question guide, and it was really important because sometimes we can be very, very jargon heavy when it comes to asking these questions. So we really worked really hard to develop questions that would be as relatable and close to what people can understand in those communities. And some of those questions were, who do you trust when it comes to health information? Do you have a healthcare provider who you can go to if you have a health issue? What are some of the health issues you know that pregnant people in your community face? Just to name a few. And even better, have you ever heard of maternal mortality or maternal morbidity? Next slide. So of the 31 participants, they were aged from 23 to 57 years of age. They all self-identify as African American or Black. All respondents were pregnant or parents. And once again, we covered Austin, West and East Garfield Park, Lawndale, Bellwood, Inglewood, Chatham, and Beverly in our focus groups. So some of the themes, the results from those focus groups were, there was a need for support outside of medical care. Sources of health information are varied, and they're not singular. They don't go to like one place. There was a need for strength and connection with their medical providers. Their familiarity with the lived experience of the postpartum period and maternal morbidity and mortality, but lack that medical information or that terminology when it comes to those terms, and differences in language and associated gaps in understanding. So we wanted to throw in some quotes here because we thought it was important as we think about how we disseminate this information to those stakeholders out there. Like, what are folks actually saying? And so one of those things that we talked about, needs for support outside of medical care, was one of the main problems within our community is we don't necessarily have a strong system while we're pregnant. We really don't know who to talk to or who we could depend on, because we really, most of the time, we really only have ourselves. The next theme were about the sources of health information that are varied and not singular. And a couple of quotes on that was this: I definitely don't show trust to the doctor, but my mom and all the women that have multiple kids and my family, I do trust. And another quote was, I would definitely say it's a combination of the health providers and then like the elders of my family, but I'm big on research and stuff, so I'll research everything. And for us, that could be family members, other community members, maybe they're attached to case management, maybe it's not a healthcare provider, maybe it is a health provider. And then of course, internet. Google is usually one that comes up often. We know Google ain't always our friend in the community. So next slide, please. One of the other focus group themes that came up was a need for strengthened connection with medical providers. Two of the quotes I'm going to bring up are the first quote being, they not really seeing what part of our environment has to play in it. What are, our stress levels what our life at home has to do with anything. They just basically diagnose us off textbook definitions. And I feel like that's not doing us no good. And the next part of that would be, I think that our healthcare industry is designed to care about people. And I think when it comes to Black mothers, that's where the least care is given. So that was some of the feedback we got from our focus groups. Next. And then the theme for familiarity with the lived experience of the postpartum period and maternal morbidity and mortality, but lack of the medical information. Two of the quotes we'll share here was, we've seen perfectly healthy parents or mothers just don't make it out of childbirth. And I'm still clueless about that. I almost lost my sister and she was perfectly healthy. She had a C-section. They were able to bring her back, but like, what happened? Like, we just don't know everything. And then one of the facilitators would say to them, okay, when I say postpartum care, what was the first thing that popped in your mind? And in our focus group, we learned that most people, when they hear postpartum care, they think depression. Next slide. They also spoke about, well, we've had these adverse health outcomes after we've had our children. And we like, dang, well, I had a setback because they're not putting the medical terms to it. And we'll get into that, some of that terminology a little bit more. Speaker 6 in this was said, I haven't heard of maternal mortality. I don't know what that is. And what is it? And somebody asked, that doesn't happen often, right? Or does it happen often? So once again, showing that there's definitely a gap in understanding because there are very high rates in those communities, or higher rates than other communities. So based on those survey findings, we show that 66% reported not hearing about maternal mortality before. And 70% reported maternal mortality is not an issue in their community. And when you go back and you look at how do you feel people are supported during the postpartum period in your community, because they're also given a little definition of that. The highest percentage think they're somewhat supported. And then where do you receive care? A lot of our folks were receiving care, like urgent care. Not a lot of PCP care providers, and then some emergency room usage. And then some folks, none of the above. Next slide, please. So how did we go into activating our social service providers? We develop a train-the-trainer curriculum to, one, build awareness of maternal mortality and morbidity and associated disparities. Two, activate those social service providers and community-based organizations as part of the solution. And three, learn from social service providers about how to improve the system for women. And so as you can see here, they show all participants surveyed reported significant increases in knowledge in the following areas. One being what's contributing to pregnant person's health, factors that contribute to mothers dying, becoming severely sick from pregnancy-related complication, postpartum birth warning signs, discussing pregnancy and postpartum health with families served, and how community organizations can contribute to addressing pregnancy complications and death. So once again, we always want to include what people are saying to us when they participated. And so from the training, some of the feedback we received was, it's crazy that this mistreatment of Black women is still going on. And I think that it's so important to have community-based programs like ours available so that we can get out this information to young women. And then another quote says, I have a better context on how we have arrived to where we are today. I understand now the mistrust our patients may have and the challenges we have with getting some of our moms into the healthcare center for care or ongoing care, or they feel they don't need to come in for prenatal care. They really nailed down why that was happening. Next slide. What did we learn based on aims 1 and 2? So for our FQHC patients, what is a primary care visit? What to expect during those visits, importance of care after pregnancy, and stakeholder engagement. Social service providers, the need for additional postpartum training and tracking systems, housing and domestic violence resources, resources aimed at people who support the postpartum person. That includes partners, grandparents, friends, aunts, uncles. Better understanding of services offered through the Medicaid managed care program. And then for community members, some of the things highlighted here are needs for support outside of medical care. Sources of health information, as we spoke about before, are varied and not singular. That need for our strengthened connection with medical providers. Once again, perceived lack of investment by providers, lack of trust by respondents. And then as we talked about when we brought up those themes, the familiarity with lived experience of postpartum period, but lack of medical information and differences in language and associated gaps in understanding of those terminologies. So that led us to the gathering, yay, our campaign. The gathering campaign is the creation, our community response based on the focus groups, the themes, and the feedback from the community. This is community-led and community-based work that led directly into our marketing of our way of trying to address the maternal mortality crisis that is being impacted in those communities. And as you can see here, we made sure, and I think I came into this work right after while they were still doing some theme analysis. And so, apologies. And so one of those things were, how relatable is what we see? A lot of folks are very visual, correct? And sometimes you want to see something that relates to you. So the imagery was important. How the folks looked, what it means to have very simple language and language that's responsive to the families that we were trying to reach. So we created the gathering. We started in June of last year. We had 6 community members onboarded as community health workers to go out in their communities and share this information out. We also had a website and QR codes for our providers to go back and also share this information within their settings. But we were really proud of our boots on the ground because they were able to go out there and put this in the hands of families. So they were much more aware about what's going on in their communities. And so as you can see, we make sure that their voice matters. And we're not just saying postpartum, we're using words like after you give birth, before you give birth, while pregnant. And all of those are important because what we found out, as you heard before, a lot of the terminology might not always relate to the folks that we're caring about. Next slide, please. And so we have a digital campaign that went with that as well. And once again, we have fact sheets that people could bring down. It was the gathering. We had the landing page, during your pregnancy fact sheet, after you give birth fact sheet, family and friends fact sheet. And then I want to just take a little moment and to just share the glossary of terms for doctors and clinics. And so for us, it was important to highlight the different terms that as providers and folks who provide care, when we use those terms, is a part of that dismissiveness that our respondents are feeling, is because when they hear those terms, they don't relate to them. And better yet, the terms that they are using may be dismissed by their providers because they may not understand what the respondent or the patient or the person they're providing care to is sharing with them. For example, and it's my favorite one, in fact, is when I was growing up, I'm a mother of 6 myself. And one of the things my mother would say to me is, hey, Tam, please, go back in the house after I've had my babies, because if you don't, you'll get a setback. And if I would say that, right, in any other room, that could mean a lot of different things. But for me, and my knowledge at that time was that something medically could happen to me if I don't follow my mom's instructions and go sit down somewhere because I just had a baby. But when a provider may hear that, they may think, well, she just had a baby, maybe, she's having some financial setbacks, can't go to school, there's a setback in life. But honestly, that's really not what that means in certain communities. And so I highlight that because that's some of the disparity that we saw when we were having these conversations. And so again, we have this glossary of terms so that those providers can be able, when they hear these terms, they'll understand if someone, once again, uses a term like my family, sugar runs in my family. Well, sugar is usually associated with diabetes in the community, but that's not always a term that's used. And we also have a gathering video and some other social media graphics that we share. Aim 3 is our policy advocacy piece. Once again, we are embedded in making sure that the work that we do at Everthrive Illinois is working towards improving and achieving birth equity throughout. So our community informed policy agenda is community clinician and social service providers and steering community engagement presents an opportunity here to develop a community informed and responsive policy agenda, addressing structural barriers to healthy pregnant and postpartum people and their families. Our policy accomplishments to date have been the expansion of the Illinois Medicaid postpartum coverage from 60 days to 12 months, yay, and the expansion of the Illinois Medicaid to cover doula and home visiting services, which we know to be important because when those issues for those folks come up, they have a support system in place that can really help assess and make sure that they're getting their needs met and addressing their risk. Next slide, please. CCMH accomplishments, next steps, and acknowledgements will be taken over by Jenna. Thanks, Jenna.
Thank you. So I won't go through these line by line because we just discussed it, but one thing I really want to underscore over all of these key accomplishments has been dissemination. We have in forums like this and in forums such as provider grand rounds at most of the major medical systems across the city, and informal dissemination spaces like academic conferences and published manuscripts have really worked hard to get this information out there, especially the community voices that Pamela highlighted in her piece, because those we think are the most important, speaking to the lived experience of birthing and postpartum people in Chicago. So next steps, the 2023 policy agenda is implementing recommendations and lessons that we've learned so Everthrive's working for that. And then we're also working on proposals within this partnership that we've established between our organizations and individually to really do the best that we can to expand the work that we're doing and really create sustainable change. So just want to acknowledge the project team for Alliance Chicago and Everthrive Illinois, the Northwestern University project team who helped us with the qualitative analysis, the University of Illinois at Chicago project team, the Illinois Perinatal Quality Collaborative, the participating community health centers, and of course, last but certainly the most important, the people with lived experience who were key advisors and informants for this work. And then this is our funding acknowledgement, and that is all from us. So we can turn it over to the next portion of the program and I'll stop sharing.
And Jenna, I also wanted to share out, we had this awesome opportunity to invite our focus group participants back and to show them what their input led to. And I want to tell you, these people that participated were blown away by the opportunity to see that their voice truly mattered, and that this led to, as Jenna pointed out, we've been just, listen, call us, we're coming. But disseminating this great information, we've done it at faith-based, but organization as well. But I think the most important part was we were able to convene them back together, some of them, and be able to just share out the importance of how we do these efforts, and the importance that they are able to look back on and see the promise of using voice. So.
Wow, well, this is a very tough act to follow. Both of you were phenomenal. So I just want to take a second to just bravo, hand clap, bow down, all the things. And I feel like I should probably introduce myself for those of you who don't know me. My name is LOreal Thompson Payton. I am a health and wellness journalist for Fortune, and also a forthcoming author, and just someone who's really passionate about this work. I'm a new-ish mom. I don't know, when does the new wear off? I'm 18 months in, so I'm in the thick of the postpartum care that you all mentioned and the importance of it. This topic is near and dear to me for so many reasons, and something that's top of mind for me right now, and listening to everything that you all are discussing and working on, is the story that is coming out of Texas about those parents, the Black couple who recently had a daughter, and they had a midwife instead of going to the hospital, and essentially were penalized. Their daughter was taken from them. And it has filled me with so much rage, right? Because we know that midwives can help improve maternal health outcomes. And so it's like we're being penalized for that. Can something like that happen here in Chicago? I have been like, since I knew I was moderating this panel and this was the topic, of like, this is something that's been top of mind for me, and I imagine others as well. So would love to hear from both of you, your thoughts on that. And if so, what we can do to prevent it.
Yeah, that's a really good question. I would say, I am not an expert on all of the legal ramifications of, and yes, that story was absolutely heartbreaking and feels like it could not have happened in a developed country with, quote unquote freedoms for patient choice. We know, the tenor of the national environment around patient choice and reproductive choice is negative, in a lot of states, particularly ones that are restricting abortion access and that sort of thing. I will say, one wish we have as we continue this work is really exploring patient autonomy and decision making, since that was not necessarily a scope of this work. And, looking at clinical spaces outside of the FQHC space, so birth centers and other routes of care delivery is definitely something I think we would like to pursue, to have more inclusive picture of what the landscape looks like for giving birth in Chicago. I will say, you Pamela shared so many quotes about mistrust, and I think stories like the one in Texas, do not improve that at all. Especially thinking about, in Chicago and in Illinois, the reporting requirements around substance use and how prenatal patients may feel stigma as it relates to or fear of reporting substance use so that they don't suffer any consequences. So I think there's a lot of work to do. I can't really speak to the legal pieces, but I definitely think that the more we can do to uplift patient voice and work to improve patient decision making is really key to preventing stuff like that happening. I don't know, Pamela, if you have any other thoughts.
No, I would agree. Not aware of any legal ramifications here, but as you heard, as we were talking about the expansion of doulas in that space, I think is a critical part. Not just doulas, but midwives as well. Once again, we've been trying to make sure that community-based doulas are part of that process, because we want to make sure we're supporting the mom at all times. I, like you, L'Oreal, feel truly enraged that this is still happening in 2023. Because one of the things, because we have this opportunity to engage high-risk pregnancies. So for someone who has made the choice to be in a space that sort of reduces some of that anxiety around giving birth, which, I mean, LOreal, you new to this, I'm old school. So, but knowing that anxiety that exists and knowing that a lot of people are, are aware of how poorly you can be treated. And so if someone made that choice, this is my personal thoughts on that, I feel that it's a miscarriage of the families that we serve. And I would pray if something like that happened here, that we would be at the forefront of advocating for that family.
Absolutely. Pamela, there was a quote, and I didn't write it down exactly because I was like, trying not to cry reading it, that you read from one of the participants that wasn't aware, like what is the maternal morbidity rate? What is that? And because I knew a lot about it going into it, had high risk pregnancy because of IVF and age and all those, different factors, and would see like Beyonce and Serena almost died giving birth. So what hope is there for me, like regular Black girl out here in the world? And the fact that it's like not even so much misinformation, but almost no information is truly scary because people's lives are at stake. The other participant who mentioned about her sister being super healthy and having a C-section and they almost lost her on the table, like that was, I had a C-section as well. And it's just kind of like, I am lucky. I deliberately did not read a lot of stories when I was pregnant as a form of self-care. I couldn't. I had to protect myself, protect my peace. And still there was that fear when we went into the hospital that morning about like, I may not walk out of here. And what I love that you all touch on is that community engagement piece, because it does require, and Pamela, I love what you mentioned about cultural care and meeting people where they are, because there's so much focus on prenatal care. And we all know that that's important, but it's kind of like, once you have the baby, it's like, all right, I'll see you in 6 weeks, good luck. So why, just kind of like drive it home for the people here and maybe watching the recording, why is it like postpartum care equally as important in the fact that we need to drive that home to people who are pregnant? Because I think too, they can think, all right, once I have this baby, then like it's all done. And there's so much focus on the baby afterward that everyone kind of forgets the birthing parents and the parents in general and the caregivers around that. So there was, a multitude of questions there, but like, why does postpartum care matter? How do we make it more accessible and make sure that people are aware that it exists and it is important?
Do you want me to start? Well, first of all, I just want to say thank you so much for sharing your story and sharing your birthing and postpartum experience. Any type of way that we can highlight the experience of all sorts of people who are going through this, I think that's a key piece to this, right? Is that to your point, there's just not a lot of discussion or uplifting of the experience of Black parenting and pregnant people going through care, and that was a core mission of our work, and why it was so exciting and gratifying to see what Everthrive was able to pull together based on what they were hearing in their focus groups. So thank you. What I would say to answer your question is, there is a lot of attention really when you look at maternal mortality and morbidity research, there's a lot of attention on the prenatal period and actually the birthing encounter, like what happens at the hospital. Mm-hmm. And there's less attention to the postpartum period. And it's interesting because if you look at pregnancy-related deaths, pregnancy-associated deaths, 40%-ish happen in the postpartum period, so that's a significant amount of time. But for some reason, and that tide is shifting, I would say, from a research perspective, from an intervention perspective. But for a long time, there's a lot of focus on the prenatal period, or if there was a focus on postpartum, it was depression, which is why you can saw that in the focus groups too, where there was so much education and interventions and research around postpartum depression that now it's almost like a combined term where postpartum isn't even reflective, or postpartum is so much more than depression care. And while that's a truly vital piece to postpartum care, there's a disconnect, I think, between health providers and patients about what actually is needed in the postpartum period. You know, a lot of what happens, a lot of patients go home and say, oh, I just had a, you know, you hear in the maternal mortality review committees, they do reviews of all the deaths in Illinois, and you see these highlights of this patient had a headache and came in and was turned away, or didn't realize that a headache was a sign of something much more serious. And that's a failure on the healthcare system, both in terms of bias and not listening to patients, but also in terms of education of what's important for patients to monitor, and also to bring in caregivers and you know, patients' families and anybody who might be you know, who might care about that patient, which is why, again, it was so important for Everthrive to put together a family and friends fact sheet, because it's really a community effort to save these women. And I do feel like patients, especially postpartum patients and pregnant patients, kind of feel like they're going through it alone. And I don't know if it seemed like maybe that's what you felt a little bit, but I think that's like a wider experience. So there's just a lot of, and I also think, sorry, I'm kind of rambling, but a lot of also what we see is that, you know, there's a lot of patients have competing priorities where it's like, I have time to take off work to take my baby to their doctor visit, but I don't have time to take care of myself. And so you also see that kind of the social determinants of health piece, where patients have to prioritize the well-being of their kids versus the well-being of themselves. And so how does the healthcare system meet patients where they're at in terms of resources, in terms of flexibility and availability of care, you know, telehealth, that sort of thing. And it just ways to really keep that engagement with patients in a really critical time. Pamela, do you have anything else? Oh, go ahead.
No, I wasn't sure. Oh, I'll just say real quick, because that community component and having the friends and family essentially enlisting them, because like you said, postpartum has become so synonymous with depression. Like it's one word, like you said, postpartum depression. And I didn't know that perinatal depression was a thing. And that's what I experienced, a lot of PTSD from, we had several failed IVF cycles. And so once we did get the positive test, I was just like super anxious that something bad was going to happen, because something bad had happened all the way up to that point. And it was like right after my daughter was born, and I had still a lot of swelling, and I just kind of ignored it, and like blood pressure, and my sister like kept on me. She was like, did you make your appointment? Did you make your appointment? Did you make your appointment? Like, I'll make it for you. What's the doctor's name? What's the telephone number? And we all need, we need someone like that who is going, because like you said, my mind was on, I was like, I got to feed this baby. I got to like keep her alive and like do all this, you know, these things. And so she was the one who was really adamant about, because everyone says it takes a village to raise a child, and I'm like, yes, and also the mom, like can't forget about
the village
us.
got to carry the mom too.
Okay. Yeah.
You know what, L'Oreal, you really bring up a huge point, because once again, as we were developing this material based on what we had heard through our focus groups and the themes that came out of that was a big part of that, because we ourselves have been so dismissed sometimes in this space that we sort of disregard some of those symptoms and signs. So it's also important that the families that surround this family and this birthing person have ways in which they can engage. Like, what do I do if this person is like, oh, I don't feel like going today? Yeah, something's going on. You might need to go today. What can I do? What type of information do I need to have on hand so I can help this person? And it's not something that needs to be long and drawn out. Something as simple as knowing a doctor's number. What clinic do you go to? You know, if you only been to the emergency room for care, is it someone that you've talked to? What did they give you? What was the follow-up notes? There are the simple ways in which we can help people support those folks that have just had a baby. And once again, that postpartum piece is so critical, because it does become about the baby. And a lot of times, it's not, as we said, it's not just depression, but women are literally dying because they are being dismissed and not aware of all of the risk factors that are associated with having a baby, and then this happens, right? And so really for us, when we came up with the gathering and being able to share those pieces out, if I go to my doctor and I say, I'm having a setback, I want my doctor to acknowledge that I'm not talking about a financial, I'm not talking about I lost my apartment. I'm talking about something is medically happening to me. I don't want to say I don't know the word hemorrhaging, but I could say I've been bleeding a lot more than I thought I would.
Yeah.
Well, keep an eye on it. So we want to take that narrative out of it. And then someone goes home and ends up in the ER and doesn't make it home. So for us, when we created the material, it was really making sure that we created the village from the provider to the folks that support and to the mom to not dismiss her own feelings about what's going on with them. So it's really important.
Yeah, and I just want to say too, one thing that we talked about with the FQHC stakeholders we worked with is that a lot of them were really well-intentioned and only had a 15-minute visit to do all this stuff. So that's the other layer, is that, there is implicit bias and there is work to be done there, but also providers do see what's going on and they do want to help. So that's why the glossary of terms was really important, because it was a partnership building rather than just saying you're not listening. It was more of like, here's how you can listen and here's how you can better serve your patients. And we, like I said, we took this show on the road to a lot of different spaces. And one of them was we went to grand rounds at most of the medical centers in the city, and a couple, and also FQHCs that we worked with. And the providers were so excited about that glossary of terms, because again, they see what's happening. And I think it's kind of like, that I'm going to butcher this phrase, but we all suffer under white supremacy, right? It's the same thing. We all suffer when there's inequality and inequity in prenatal care and postpartum care. Not patients obviously suffer the most, of course, but providers suffer too if they're not open and understanding of kind of the whole person that's right in front of them and able to fix them. So it's a systemic issue too, right? Of what can you achieve in a 15-minute visit is not much, but what do you do beyond that? How do you instill care coordination and system resources and community referrals, and again, engaging the families to have that kind of supportive layer to accomplish the things that you maybe are not able to in that really short time period. I
love, cannot stress enough how much I love this glossary. I didn't just like, where can we publish this? I want everyone to know what it's, because I've written articles that because there is that gap in cultural care, essentially, like culturally relevant care, especially in healthcare. People are going undiagnosed and issues are going under, like they're either unaddressed or they're underdiagnosed. And there's, I wrote recently an article about how like depression and anxiety and these sort of things show up differently in Black women. We may just say like, oh, like I'm feeling down, or I'm, like I'm going through it, or whatever sort of thing. It's like what that means actually is like, listen, I'm low-key depressed, but I have a to-do list that's about a mile long. And it just kind of like, because we're not speaking the medical terms, it can get overlooked. And it's just so important. That's why I love the idea too, like meeting people where they are literally. Let's go to the nail salon, let's go to the grocery store, go to the cookout, like whatever that is, because that's where the people are. And it requires a bit more work than people may be willing to put in. It's definitely more than you may have learned in med school and whatever other training that you did, but it's so necessary because like lives are literally on the line. And we do have a question in the Q&A, so I just want to read it. Sandra is curious, says, good afternoon. I would like to know what relationship you have with the health department. I didn't hear Woodlawn as one of the communities you engaged, and thank you. So whoever wants to take that.
Yeah, I would say we have, so this specific partnership involved the health department, both the Chicago Health Department and the Illinois Health Department as steering committee members. So we had a group of maternal and child health community-based organizations, public health organizations, FQHCs, and advocacy groups as part of the steering committee. That was another layer to kind of informing the work that we were doing. And I'll let Pamela talk more about Everthrive's relationship with CDPH, but Alliance Chicago works really closely with CDPH when it's warranted for public health advocacy and interventions and that sort of thing. So it's kind of a mutual partnership, but specifically they were engaged in this work. And then we've also been engaged in their Family Connects home visiting program, which I'll let Pamela fill in a little bit more on.
Yes, so thank you for that question. Of course, we've hit all the neighborhoods, I like to say, because we, once again, as I shared, we had an opportunity to go to health fairs to give out some of this information. And as you know, some of those really intersect between our South and West Side communities. To be exact, we do a lot of work with the Chicago Department of Public Health and the Illinois Department of Public Health. So maybe not Woodlawn specifically, but the overarching work that we do in collaboration with them, from everything from their flu and COVID-19 campaigns to, of course, this surrounding achieving birth equity. Then, of course, Family Connects has a community advisory board that sits in the South Side regions, in which we share a lot of this information as well. And we have a lot of partners, including those from health departments, involved in providing information so that we can continue to achieve birth equity throughout these neighborhoods that have been most impacted. I hope that makes sense.
Thank you. Yeah, and I just want to put out there too, if anyone has any questions, feel free to drop them in the chat or the Q&A. Don't be shy. And I have one more, and this again is totally biased just based on my own experience, as I mentioned, with like perinatal, postpartum depression, anxiety, like all the things, because I think in our society, there's just so much emphasis on physical health. And so you see that in the prenatal phase and with like your 6-week appointment. I mean, they do the Edinburgh scale. They survey you for symptoms and signs of postpartum depression. But like I said before, I didn't know that there was a such thing as perinatal depression, like while you're pregnant. And so where does mental health care fit in? Like, we know it's important, but give stress, like why that matters. And because it does impact our physical health in both perinatal or prenatal and postpartum periods. So just love to hear from each of you about the importance of focusing on mental health as well.
Yeah, absolutely. Well, first of all, I would say that, and I don't want to misquote the statistic, but there is a significant proportion of maternal deaths that are due to some sort of mental health or behavioral health condition. So, we talked a lot, and in the FQHC space, there was a big focus on the physical health, to your point. All of the sites we worked with were looking at gestational diabetes, but a couple of them were looking at depression for that reason. And I think it's, again, kind of how you said before, it's hard to track because it displays in people differently. And again, sorry to keep harping on this, but if you have 15 minutes to address the needs, a patient might say, well, I feel like I want to talk about my hypertension, not how I'm feeling, or, it could be a communication issue between the medical assistant who's kind of doing that depression scale survey and the doc. There could be that information transfer, that information loss. So there's a lot of kind of like on the ground issues that contribute to the ways that we do not catch or capture mental health. And it is so important because not only is it separate for physical health, but as you said, it interacts with physical health. And you see a lot of people who have chronic conditions of any kind, not just in pregnancy, but also during pregnancy, have an intersection of depression or anxiety with that. And so I think there does need to be some sort of shift in medical care about, really understanding how those intersections interact and what you can do, especially during the prenatal and postpartum period, when in theory a patient should be engaged with the medical system pretty often because of how often they have to go and seek care. We have a FQHC in Chicago, one of the partners who recently implemented a telehealth behavioral health visit for all of their prenatal patients. And that's just one example where it's kind of just like they saw this going on. But I think a lot of it has to do with, we're not screening the best that we can, and then we're not referring for care the best that we can either if someone screens positive. So again, I think it is a health system level cultural shift. And I think also, as we all know, mental health has its own stigma attached to it, which makes it, less reported, and again, less diagnosed. Pamela, you have
Thank you
anything else?
so much. No, I think you hit that right on the head. I also want to share some exciting news that we are going to be doing. So the gathering, of course, wants to encompass that very piece, because we don't want people walking around thinking that maternal mortality means depression. And so we are going to be engaging in a process to add a page on mental health.
Oh, love
As
that.
we listen, it's that's the evolution, right? Because we know that even if you thought that was the case, even if you thought I've been depressed, what did you do about it? Did you just sit at home and you were depressed? And so for us, we know that there are some shortages in our healthcare system in accessing mental health services. That's why it's exciting to have things like telehealth in place, but also to let people know that these are where these resources are, but we have to be very intentional about that, because this is not a resource heavy department that people can access. And along with reducing stigma, they need to have somewhere to go. And they need to understand when they need to go. And so really, once again, the gathering is going to be that meetup place and meeting people where they are to ensure and allow them to understand the importance of not just the physical, but there are some mental health issues that play a huge part. Everything from substance abuse, and other factors that come up. And so we want to make sure that we're continuing to educate folks through the work that we do. And so I'm excited about that piece to come out, and we start working on it really soon. And but thank you. It's a great piece because it is really important part of taking care of the whole self. And we can't just concentrate on bits and parts.
Yeah, I love too that you both recognize the stigma. And I remember even when I first started going to therapy back in 2016, and I wrote about it because I'm a journalist, and my aunt, I posted it on Facebook, and she was like, she texted me on the side, well, niece, you have a family and husband and friends who love you and care so much about you. And I was like, yes. Like those two things aren't separate. It's like, I can go to church on Sunday, I can go to therapy on Monday. You can do both. But there is so much, it's gotten better, but there is still a lot of stigma and taboo in the Black community, especially around mental health. Even after I had the diagnosis from the doctor about postpartum depression and was contemplating medication, and that family member was like, well, you don't want to do that, you're breastfeeding, and you don't want to, and I was just like, that's not how it works. Like there are medications that are safe to take while you're breastfeeding. And so we have a lot of educating to do, and it starts with the conversations. And that's why I'm so open about my experience, because it's very easy to look at someone online and social media and think, well, they have it all together and no. So like normalizing it by having the conversations and then showing people where to go and what to do with that information by getting the help that they need, and understanding that there's not any shame in that, and that it's good for you. The same way you'll go to your annual and get your physical and like that health part of it, your mental health deserves the same time and care and energy. So getting off my little soapbox.
Come on, because we're going to beat that soapbox today.
Yeah.
And once again, like what Jenna was saying, right? We have normalized not being okay. And we know that we need to provide much more systemic changes, into this space so that we are addressing both.
Mhm.
And we also have to improve, our grandmothers and our great aunts.
Yep.
I mean, if they would have said that to me, if somebody would have said that to me, it's dangerous. Like I wouldn't have given it a second thought,
Mhm.
right? Because at that time when I was birthing, they was my go-to people. They trumped anything anybody else said, I mean, why are they giving you that? And if you can give them a good answer, yeah, you probably wouldn't take it. So we have to really infuse that education part into not just mom. Everybody needs to hear what mom's hearing, right? And so that's why that family and friends piece also gets an upgrade when we talk about that mental health, because they are a critical part of ensuring that folks are not shamed into not getting care.
Love that. Like you said, it takes a village, and I did in the same way. Had some very type A, like Google Doc with the birthing plan, or no, what did our doula? She said birthing preference, so not get so like caught up in the plan and very rigid. Because did I mention I'm type A? So, but because I had the experience, like I said, with the perinatal depression, I knew that I would be more at risk likely for postpartum depression, and had essentially my circle of care, my sister, my best friend, my husband, and everyone is like, these are signs I need you to look out for, because I might miss them. I might not be aware. I may just be going through the motions, but like, here's what to look out for. And, like call it out, and, and help me essentially. I like gave them a heads up. It's like, this is something that could happen, and I want to prepare for it as best I can. And they definitely rose to the occasion, but it took their help and their support and everyone who's around me to do that and to come out on the other side. So you can't neglect
And
that
LOreal, we
portion.
want all families to have that. That's
Yeah.
why it was, once again, the gathering. The gathering means just that we need to gather all our resources, gather all parties, so that we can support this person prior and after a pregnancy. And how do we do that? Look out for this, because I might not recognize that. And we need that, right? So we need to educate people how to help. And so once again, I'm just grateful I was a part of it, because I recognize I missed the village a few times. Maybe baby number 5 and 6 got some village opportunity. And so I'm just glad they still alive and well. Based on my experiences from back in the day. But once again, the gathering and the work that Alliance and Everthrive Illinois did to, even prior to me coming, and then just being a part of the strategies to get that out into the community, boots on the ground. That's important. That's how we create villages.
And I think too, as we're talking about equity, one really key piece that of the work was that the community health workers who led the focus groups, who looked like the communities and came from the communities, they were also part of the research team and part of the dissemination and part of the development. So it's not even just that we're uplifting the voices, we're making sure we're reflective and responsive to the communities that these voices come from, and not, coming in and saying, we're studying you, and then we're taking your stuff and leaving. That's a huge critical equity piece, I think, if we're going to make any sort of systemic and culture change as it relates to this, is not just studying folks and then kind of piecing out, but also making sure that communities are partners in the research work, and studying and the improvements that need to come.
And that's what was so unique about this process, because we didn't send in researchers, so to speak, but we had those community health workers talk, right? Have a conversation about these questions. And so I think that was very unique to this process. And then being a part of integrating them into coming up with the themes that we shared earlier, that was a big part of that, because had they not been in that space, we might not have a glossary of terms that we can brag about today. And so once again, that was a big part of uplifting the voice, but also a big part, even after getting there, is to integrate folks into that research part.
Mhm. That's so important. It's community care, it's cultural care, it's all of those things that
Yeah.
like y'all have done really, really well and resulted in these policy accomplishments. And I know you're working on a mental health piece. Can you share with us kind of what's next, where y'all are going with this and the research and other initiatives that you may be involved in, and if it's applicable, like how people can support you as well?
Sure, well, I'll just say, like I said, kind of in the slides, we're constantly hustling for more funding to get this, and like I said, venues to get this information out there, but also funding to sustain and expand the work. So fingers crossed, we have some proposals out there to really, like I said, take a lot of this work to the next level. And that's really, I mean, part of the game, right, of this work is that you have to have the funding and you have to have a lot of the pieces in place. So we're really grateful to folks who want to support that effort. I know Everthrive has a fundraising page, so I'll just plug that. But also, I think that as long as folks are sharing and continuing to highlight the work that we're doing, and you know, the links, I think they're all on these slides, and we can work with public narrative maybe to get the links out to these folks, but they're all live, they're all easily shared, they can be downloaded. I mean, they're asynchronous to the work almost, you know, they can have a life of their own. So anybody who wants any of those information, those tools, feel free to reach out to us, or we can work with public narrative to disseminate those.
Great.
And once again, go to everthriveillinois.org, go to our website, and you will find the gathering. Once again, we've taken the show on the road. There has been interest, once again, about expanding that glossary, because there's so many different communities that uses different verbiage that we know that our providers might not recognize when they hear them. And so we want to ensure that they have that language so we can have some cultural relevant conversations when we're trying to get care. And for us, once again, look up the gathering, share the gathering out with folks. We know how critically important that educational piece is, especially if you know of folks who really want to get the word out and save some of these mothers and those babies. The other part, once again, is we're going to be working on adding the mental health piece. We see that there's a gap there as well in accessing mental health services during these periods. So it's going to be critical for us to continue to grow the gathering. It is organic. It is one that can be tailored to different organizations. So we're really proud of that, that work that we've done, and always willing to share a presentation on how people can be more inclusive of the crisis that's going on in different communities, and how they can use this to support their efforts in ensuring that people get great care and they'll wear bad care.
Yes, absolutely. Jenna, Pamela, thank you both so much for sharing all of your insight and expertise. I've really enjoyed this conversation, and I hope everyone listening has as well. And just thank you again for taking the time. Really appreciate it.
Thank you so much.
Thank you for having us. I appreciate it. Thank you.
Thank you all so much for being here and sharing such great information. And thank you all for joining us in the celebration of healing. This has been the Power in the Public Narrative series, and we'll be sure to share with you all the recording from this session, as well as the materials provided. Have a great afternoon.
Thank you.
Bye.